Okay, welcome to my talk on the clinical assessment of the patient, which is mainly meant for your 3 surgery posting. Okay, today we will talk about the examination of the breast and axilla. And this, you must all realize by now, is a very important topic for the exams. So you must be very familiar with the examination of the breast, in particular about assessment of a patient with breast lump.
Okay, before we go on to the examination proper, it is very important to get a good history as far as clerking a patient with a breast lump. First, you got the introduction where you get a consent. Okay, the breast examination is a very important examination where you need the consent has to be taken and full explanation given, and the patient's confidence has to be obtained. On to the presenting complaints, we have got the main complaint is the lump. Is you ask the patient for the site of the lump and where exactly is the lump and the other features. Is it mobile? Is it painful? These are all important questions you have to ask the patient. Then, is it single or multiple? Is there a surrounding swelling? Is there any discharge from the lump or from the nipple? And then like nipple problems like any ulceration or pain in the nipples, axillary swellings, pain in the axilla, skin changes such as discoloration or ulceration. Okay, these are all very important questions that you have to ask the patient. And the history of presenting complaint is very important. Go through the history, the details of the lump, and also the progress of the lump, the pain, and the mobility. Okay, as far as so these are the some assessments you got to ask the patient of the breast lump: site, onset, size, consistency, tenderness. These are all important things that you got to ask the patient. Okay, next, as far as breast is concerned, there are some other important information that need to ask every patient with breast lump. First, risk factors: the menstrual history, menarche, onset of menarche and menopause, family history, the parity of the patient, the, the pregnancy status of the patient, the number of pregnancies she has undergone, and the history of breastfeeding, details of the history of breastfeeding, any intake of hormones, especially the oral contraceptives or the hormone replacement therapy if it is postmenopausal woman, and also history of cancer or some form of disease in the contralateral breast. Okay, so all these are the risk factors that you have to go through with the patient. Okay, as far as the breast is concerned, there are a number of factors. The most important is to decide whether there is benign or malignant. The lesion is whether, or the lump is whether it's benign or malignant. And there are a number of factors in the history to consider whether it is benign or malignant. The first one, the first condition is called the age. Age is the utmost importance. Young, middle age, and elderly lady. So these are the 3 age groups which you must be carefully, very important to consider the age. Secondly is the chief complaint. Most of the time is a lump or swelling, and you have to go through the features of this lump to decide whether it is likely to be malignant or benign. So as a medical student, I think it is very important to be asked or judged on your findings of the lump. You must emphasize whether it is benign or malignant in the features of the lump. Next will be the onset and progress of this lump. Okay, small, how fast it increases in size, is there a sudden increase in size, and whether it is painful or otherwise. Next is your family history and other risk factors. Family history is one of the most important factors to consider in a patient with breast cancer. And lastly, symptoms of metastasis, especially metastasis to the axilla, presence of axillary lump. The other important sites will be the lung, liver, and bone, especially the spine. So it's very important to go through these features in detail with the patient and decide whether lump is likely to be benign or malignant. Okay, now we come to the examination proper. First, we have got the general inspection. Under general inspection, you look for asymmetry of the breast. You look for breast with associated nipple retraction or puckering. Look for evidence or features of Paget's disease of the nipple. Also look for Peau d'Orange, which is invasive ductal carcinoma, okay, which produces this Peau d'Orange sign. And also look for, you must be careful not to miss a congenital nipple inversion. Okay, so this in summary, this picture shows you the various things that you look for in inspection. You will look at symmetry, swelling, masses, skin changes, and nipple changes. Then you will look for areola and nipple deformities, ulceration, cracking, and discharge. Then you look for Peau d'Orange, okay, and then this is a close-up view of picture of a Peau d'Orange, okay, where it looks like the skin of the orange. Okay, next we look at the skin changes that can be associated with breast lumps. First, there are four common types of skin changes. One, scaling of the nipple associated with cracking and ulceration. Erythema, inflammatory changes that occur in the lump. Third one is puckering or dimpling, and the fourth one is Peau d'Orange. Okay, these are very important skin changes that you must look into. Now, the details of the skin changes. First, you have the scaling. Scaling of the nipple and or areola are usually associated with erythema and pruritus and are typically features of Paget's disease of the breast. Paget's disease is associated with underlying in situ or invasive carcinoma of the breast. Okay, that is scaling of the nipple. Secondly, you got erythema of the breast tissue has a wide range of causes, including infection, example mastitis or breast abscess, trauma, example fat necrosis, and underlying breast cancer, the most important of all. Thirdly, you got puckering of the breast tissue is typically associated with invasion of the suspensory ligaments of Cooper of the breast by the underlying malignancy that results in ligamentous contraction that draws the skin inwards, leading to puckering and dimpling. And finally, you have got the Peau d'Orange, which is the dimpling of the skin to resemble that of an orange peel. This occurs due to cutaneous lymphatic edema. The dimples represent the tethering of the swollen skin to the hair follicles and sweat glands. Peau d'Orange is typically associated with inflammatory breast cancer. Okay, the next part of the procedure examination is to ask the patient to stand with the hands pressing onto the hips here. Okay, pressing into the hips, which helps to contract the pectoralis major muscle. Okay, so with the hands pushing into the hips, you inspect to see, and this pressing the hands into the hips will contract the pec muscles, pectoralis muscles, which will then allow, if any mass is visible, then you observe whether the mass moves when the pectoralis muscle contracts. If it is, then it suggests tethering of this lump to the underlying tissues. Therefore, this is called tethering, and this is a sign of invasive breast malignancy. This maneuver may also accentuate puckering if a mass is invading the suspensory ligaments of the breast. Okay, if the suspensory ligament of the breast is also tethered, then this will accentuate this contraction of the pec major will accentuate the puckering. Okay, this picture here shows you, see the patient pressing into the hips here. The hands pushing into the hips contracts the pec major, which therefore lumps and dimpling and puckering become more prominent. Okay, finally, to complete the inspection, ask the patient to place her hands behind the head as shown in this picture here, and lean forwards. So the breast becomes pendulous. If the lump in the breast is malignant and is fixed to the muscle, this pendulous feature may be lost. This position also exposes the entire breast and will exaggerate any asymmetry, skin dimpling or puckering that may be present, which may be suggestive of malignancy. Okay, the next part of the examination is the most important. It's called the breast examination, and this is done with the patient lying the head of the bed is 45 degrees, and I ask the patient to lie down with the affected hand behind the head. And usually it's better for you to examine the asymptomatic or the normal breast first. Okay, here this is the position. This is the patient lying propped up 45 degrees, and the breast is will be exposed here. Okay, and there are three methods. Generally, there are three main methods of examining. One is the clock face method, where you can examine the lumps from 12 o'clock going right downwards, right back until 12 o'clock again. Okay, that is the view the breast as a clock face and examine each hour from outside towards the nipple. Then the other one is the spiral method, and this you begin palpation at the nipple and work outwards in a concentric circular motion. And thirdly, quadrant method. Divide the breast into quadrants, especially 4 quadrants, and then you examine this breast every quadrant thoroughly. Okay, this is a quadrant method. Okay, this is the one more widely used method of examination. Now, how to go about it? You use your flat of your hand, not the tips of your fingers. Use the flat of your middle and 3 fingers to compress the breast against the chest wall. Okay, as you feel for any masses, if a mass is detected, assess the following characteristics of the mass, which is of utmost importance: the location of the mass, site of the mass, the shape, consistency, mobility, fluctuant, and the overlying skin, which I mentioned just now. So these are the features that you have to go look for in a patient with palpable breast lump. Okay, the other important part of the breast which must not be forgotten is the axillary tail. The axillary tail is a projection of breast tissue that begins in the outer quadrant of the breast and extends into the axilla. So from outer quadrant and it extends into the axilla. So it's very important to palpate for this axillary tail, because the majority of breast cancers develop in the upper outer quadrant. So it's essential that this area is examined very thoroughly, as done as shown here. Okay, and this is your spiral method, where you start examining the lump from outside towards the nipple in a concentric spiral method here. Okay, at the same time, the axillary tail must not be forgotten. Okay, now the characteristics of the lump is a very, very important feature to determine whether the lump is malignant or otherwise. Okay, the location of the lump, which I already mentioned, how far is away from the nipple is very important. Which quadrant of the breast is located is also equally important. The size and shape of the lump. What are the approximate dimensions of the mass on palpation? What's the shape of the mass? Consistency is of utmost importance, because consistency can be divided into smooth or soft, firm, stony, hard, and rubbery. You can categorize into any of these categories. Basically, it is soft, firm, and hard. Okay, the harder, when it's stony hard, it suggests it is most likely a malignant lesion. Most malignant lesions are very hard to consistency. The overlying skin changes are important, which must be taken into consideration. Are there any changes the skin overlying the mass? Example, erythema and puckering. Mobility of the lump is important. Assess the degree of mobility of the mass. Does it move freely? Does it move with the overlying skin? does it move with vector release contraction? Okay, so the movement is important to assess whether it is stuck to the underlying muscles or whether it is involving and adherent to the overlying skin. So this overlying skin and underlying muscles are very important to assess whether the lump is attached to them. And finally, you have the fluctuance. Hold the mass by its side and then apply pressure to the center of the mass with another finger. If the mass is fluid filled, example cyst, then you should feel the sides bulges outwards. This is your fluctuancy test. If it is fluctuant, most likely it is a fluid filled cyst, and cysts are usually benign lesions. Okay, the other important thing is your nipple areola complex, as shown in this patient here. Okay, here you've got your nipple and the areola surrounding the areas, hyperpigmented area surrounding the nipple, and also these glands in the nipple areola. This is known as the Montgomery glands. Okay, this is another view to show you the breast consists of lobules, multiple nodules, and these lobules are drained by ducts known as lactiferous ducts. So the milk that is produced in the lobules are drained through these lactiferous ducts into the nipple to be discharged. Okay, now how to examine a patient with nipple discharge? Okay, use the flat of your fingers, of your middle three fingers, to compress the areola towards the nipple as you inspect for any discharge. Okay, as shown here. Try to compress and see whether there's any discharge. Okay, if there's a history of nipple discharge, but nothing is not obviously seen, it is not visible, it's better to ask the patient to express the discharge from the nipple if she is comfortable to do so, and assess characteristics of the discharge. If she is unable, then you can try to use your fingers to express to see whether there's any nipple discharge. Now the important thing is nipple discharge is once there is discharge, then you must check for the color, whether it's blood stain, green or yellow. Consistency is thick, watery, and the amount, volume of discharge. These are all important features of various diseases. Okay, the nipple discharge itself can be milky. Milky discharge is due to a lactating breast. It is normal during pregnancy and when breastfeeding, and this usually occurs bilaterally. It can be purulent, where the pus is discharged. This is thick yellow, green or brown discharge with an offensive smell, and the possible causes include mastitis and central breast abscess. Okay, so purulent discharge is usually a sign of infection, and watery and bloody discharge, several possible causes. However, ductal carcinoma in situ is the most important diagnosis to consider. So cancer. Okay, so from the nipple discharge, you may be able to tell whether it is normal, lactating, infection, or cancer. Okay, next, after examining the breast, the other important thing in breast lumps is to examine the axilla for lymph nodes. Okay, these are the lymph nodes these are the various methods. Ensure the patient is positioned. The best position will be the patient sitting on the edge of the bed, and you stand in front of the patient. Okay, ask if the patient has any pain in either shoulder before moving the arm. Begin by inspecting each axilla for scars, masses or skin changes, and when to examine the patient, what you do is you hold the patient's right forearm in your right hand and instruct them to relax it completely, allowing you to support the weight. This allows the axillary muscles to relax, so make the axilla more accessible to examination. Palpation should be then performed with the left hand. The reverse is applied when examining the left axilla. Okay, so these are the various things that you do. If the patient's right axilla you want to examine, you support her arm with your left hand, and then with your right hand, and then use your left hand to palpate the axilla. Hold the patient's right arm in your right hand palpate the patient's right axilla with your left hand. So this is a very important picture that you must remember. Examination technique of examination the breast, and you must be able to examine the various groups of lymph nodes in the breast. Okay, the anterior group of lymph nodes or the pectoral lymph nodes, central or medial lymph nodes, subscapular posterior group of lymph nodes, humeral or lateral lymph nodes, and apical lymph nodes. So the pectoral lymph nodes or anterior group is examined using your palm towards you, the palm facing back towards you, and you feel the inner surface of the pectoralis major. The central group of lymph nodes can be examined by the palm facing medially against the chest wall. The subscapular or the posterior group of lymph nodes, palm facing away from you. That means you are feeling for the subscapular area there. Okay, that is posterior. Okay, so the posterior group of lymph nodes. And the humeral is the lateral group of lymph nodes which are present in the inner arm, inner arm within the axilla. That's a lateral part here. Okay, here. And the apical groups, you reach upwards in the apex of the axilla. Okay, the description here tells you how do you go about examining the various groups, the 5 groups of lymph nodes in the axilla. And once this is completed, if you notice a lump, then you must describe the size, consistency, and fixation. These are very important. And the same, once you have completed, then you have to do the same for the opposite or the contralateral axilla. Okay, in this slide, you see the axillary lymph nodes, the layout, where the lymph nodes are located, and where you are supposed to palpate each group of lymph node in the axilla. Okay, this is the right axilla. So the important structures here, the humerus, the clavicle, and the pectoralis minor muscle, which is attached to the coracoid process of the scapula. And the other landmark is your scapula, where the subscapularis muscle is there. Okay, so these 5 groups of lymph nodes are related to these structures. Okay, the first one is your anterior group of lymph nodes related to the pectoralis major muscle here. This is the anterior group. Second one is the posterior group, which is related to the scapula with the subscapularis muscle. So this is your group number 2, the subscapula, the posterior group of lymph nodes. The third one is the medial or central group of lymph nodes here in the center, which is located on the chest wall, the chest wall, the rib cage here, around the rib cage here. So medial or the central group of lymph nodes. The fourth group is related to the humerus, which is your lateral group of lymph nodes here. So this lateral group of lymph nodes are related to the medial border or the medial surface of the humerus in the axilla. And the fifth and the last group is your apical group, which is in the apex of the scapula, also known as the inferior or infraclavicular lymph nodes, which is the deepest of all the lymph nodes. The lymph nodes from all these areas will drain finally into the apical lymph nodes. Okay, then this is another picture to show you the same thing. Okay, the humerus, clavicle, pec minor, and your scapula here. Okay, and the various groups of lymph nodes are there: anterior, posterior, medial or central. Then you have got your lateral group of lymph nodes, and finally the subclavicular or the apical group of lymph nodes. And on the patient, this is how it's distributed. You have first is your pectoral or anterior group of lymph nodes related to the pectoralis anterior here. Second one is your related to your subscapularis muscle in the behind the posterior lymph nodes, where the scapula is. Third one is your central group of lymph nodes, which is present in the medial wall of the axilla, in the chest wall. And the fourth one is your lateral group of lymph nodes related to the medial surface of the upper humerus in the axilla. And finally, the last is your apical lymph nodes below the clavicle, infraclavicular lymph nodes. So these pictures show you give you a visual picture of where to look for the lymph nodes in the axilla when you do the axillary examination. Once you have examined the axillary lymph nodes, then you have to go and examine the other lymph nodes, the infraclavicular lymph nodes, supraclavicular nodes, and the cervical lymph nodes, especially the lower cervical lymph nodes, which I have described to you in the examination of the neck and thyroid. Okay, the other lymph nodes are all you have to look for, and these include your cervical lymph nodes, supraclavicular, infraclavicular, and parasternal lymph nodes. Parasternal lymph nodes are usually not palpable.
But now we come, and finally, after examining the patient and taking a good history, now you have to provide a summary. Okay, this is a sample summary. Madam K, a 64-year-old female, complained of a lump in her left breast for 1 month. On general inspection, she appeared comfortable and well. Closer inspection of the chest did not reveal any scars or breast abnormalities. Palpation of the breast revealed a single lump in the left upper quadrant of her left breast. Upper outer quadrant, it measured 2 by 3 centimeters, firm and mobile, and there were no signs of regional lymphadenopathy. These findings are consistent with the fibroadenoma. By considering the age of the patient, carcinoma of the breast should be excluded. In order to proceed on, I would like to perform the following investigations to confirm the diagnosis. Mammogram, typically used when patients were 35 years of old, and our patient is 65, so the mammogram is very essential for this patient. Next is an ultrasound scan. Typically, it's more useful in female patients, but it is very important to be done in the elderly, in this patient, to determine the nature of the lump, whether it's a cystic or a solid lump. And finally, I will recommend a core biopsy of the breast lump under ultrasound guidance for further histological assessment of the lump to determine whether it is malignant or otherwise. Okay. Finally, after the history and examination, you should be able to derive at a possible clinical diagnosis. You must be able to suggest whether it is a benign or malignant lesion of the breast that you are dealing with. I'll show you a short video on the OSCE guide of breast examination, which is a very important exam topic.
Hi, I'm Simon, one of the junior doctors. Can I just check your name and age, please?
Yeah, it's Leola and I'm 23.
Nice to meet you, Leola. So today I need to perform a breast examination. Have you ever had one of these before?
No.
Okay. And which breast is of concern to you?
I felt a lump in my left breast.
Okay. So what this examination will involve is me having a look and a feel of the breast tissue. Are you happy for me to go ahead?
Yeah, that's fine.
All right. What I'll do is I'll let you get undressed, so taking your top things off, including your bra, and then popping this gown on to cover up. In the meantime, I'll fetch one of the nursing staff to act as a chaperone throughout.
Okay.
All right. Okay, Leola, if you could just put your hands on your hips for me, and now just press down on the hips. And now if you could put your hands behind your head and push your elbows back. And now just lean forward for me. Okay, thank you. Okay, Leola, if you could lie down for me now, I'm going to examine the breast. And if you could just put your right hand behind your head for me. Thank you. I just want to make sure that there's no discharge from the nipple. If you could just squeeze your right nipple between your thumb and index finger. Okay, thank you. If you could just switch the hand behind your head. Thank you. Now could you just tense your chest muscles, Leola? Thank you. What I need to do now is have a feel of the glands in your armpit, okay? So if I could start on the right, I'll just take all the weight of your arm, so just completely relax it, okay? Okay, Leola, I'll do the same on your left side now. So again, just relax, let me take all the weight. I'm just going to have a feel of the glands in your neck now, alright? That completes the examination. Thank you very much, Leola. I'll just leave you to get dressed now.
Thanks.
Today I performed a breast examination on Leola, a 23-year-old lady. On inspection of the right breast, there was evidence of nipple ulceration and there was erythema in the lower outer right quadrant. On inspection of the left breast, there was evidence of nipple retraction and also peau d'orange in the left lower outer quadrant. On palpation of the left breast, there was a firm, craggy 3 by 3 centimetre mass at approximately 2 o'clock. It was located 4 centimetres from the nipple and it appeared to be tethered to the underlying tissues. There were no other lumps on palpation and there was no lymph node involvement. For completion, I would consider further examinations to detect the presence of disseminated malignancy. I would arrange ultrasound scan and also core biopsy or fine needle aspiration of the mass.
Okay, thank you for joining this short session on breast examination. I hope it was useful to you, and as I always tell you, practice makes perfect. The more you examine, the better you become in breast examination. Thank you.